So we are using immunotherapy drugs already. I mean, we've been using rituximab for many, many years, but some of the more modern immunotherapy drugs, particularly the checkpoint inhibitors, we can now use. They're licensed and reimbursed, for example, in relapsed Hodgkin lymphoma that's failed an autograft, failed brentuximab vedotin. And actually we did see some data presented at ASH that may help inform our use of these drugs. So one of the abstracts was treating patients beyond progression. Now, what does that mean? Now, a progression really was defined as a PET scan-based progression. And actually, the bar for progressing on a PET is very, very low. So you can sometimes just have a new FDG avid lesion that isn't necessarily growing on a CT scan, but that would count as progressive disease based on the modern response criteria. And what the presentation we saw was patients who were treated on CheckMate 205 were allowed to be treated beyond progression under certain circumstances. And what we saw actually is that people who were treated beyond progression, quite a high proportion of them did re-enter a remission, and some of those remissions were quite durable. So I think that just informs how we use these drugs, that when we're treating patients in clinical practice and we see a new PET avid lesion, as long as the patient's well, there's no threat to organ involvement with whatever the new bit of avidity is, and as long as it's felt that the benefit of continuing outweighs any risk, then actually it is safe to continue on those agents. And I think those presentations are very helpful actually to inform our day-to-day practice, and in particular how to interpret PET scans, which in the context of PD-1 inhibitors can be quite hard to interpret sometimes.